Good afternoon, and thank you for joining us today for BHWP's presentation, Effective Use of Quick Kits for Promotion, Engagement, and Action. My name is Jim Pavlik, and I'm a Senior Program and Policy Analyst at the Behavioral Health and Wellness Program at the University of Colorado Anschutz Medical Campus. Before we dive into Quick Kits, their component parts, and whether and where they may be effective, it's worth talking about some basics about where our knowledge base is regarding nicotine recovery. And before we do that, I do want to offer a word of caution. Our understanding of addiction as a compound biological and psychological disease has really only emerged in the latter half of the 20th century, with significant advances only in the last few decades. It was only in the 1980s that scientists could undeniably confirm that nicotine was the primary driver of addiction in tobacco products. The 1980s. And here I do want to repeat and stress the word undeniably, as nicotine, being the prominent alkaloid in tobacco, and alkaloids having long been isolated and extracted from plants for medicinal and recreational use, had a lot of scientific evidence pointing to it as the culprit. Still, tobacco companies maintained a front of plausible deniability in that regard until the publicly available scientific evidence was absolutely unquestionable in that regard. And why do I bring that up? Well, what this means is that despite a century or more of investigations into the nature of addiction, there remain significant mysteries, and the ability to scientifically study cessation interventions is confounded on multiple fronts. To provide insight into the nature of this talk on the effective use of quick kits, I think it will be best to spend a little bit of time talking about what quick kits are neither effective nor efficient at. Namely, they are at best inefficient cessation aids, and at worst, they may not be effective at all. And it's important that we start here because quick kits are and have been a common tool used by governments, nonprofits, and advocacy groups to promote cessation. And while the possibility they may be useful in that regard remains, the evidence to support that belief is scant and, in my read, essentially statistically equivalent to zero. But it isn't just that there is little to no evidence that they are good cessation aids. This entire introduction is a long way to say that there is very little reason to believe that they would be an effective cessation intervention, given what we know about the nature of addiction and the difficulties of recovery, specifically nicotine dependence. Nicotine is a rapidly metabolized psychoactive drug, and in several measures of addictiveness and harm, there is broad agreement from experts that nicotine is among the most addictive and deadly drugs on earth. Measured by capture rates, that is, the amount of individuals who use recreationally who will go on to develop a problematic habit, it's about as addictive as methamphetamine. And as measured by the odds of a successful recovery per quit attempt, it's about as addictive as heroin. In fact, many individuals who have successfully recovered from alcohol or other drugs either do not attempt to recover from nicotine or they fail to do so. And many individuals who have recovered from alcohol or other drugs and also nicotine report that nicotine was the hardest of the drugs they recovered from. And there's good reason for that we can talk about on a different day. The point here is that nicotine is an addictive drug, and its most addictive form is inhaled into the lungs in short bursts throughout the day. And the most popular way to do that is through combustible cigarettes. And that thing, the cigarette, in addition to being an efficient delivery device for nicotine, also happens to be the source of thousands of chemicals, dozens of which are known to be extremely harmful to the body. Cigarette smoking causes a significant amount of deaths from 9 of the top 12 causes of death in the United States, including an estimated 80 to 90% of all lung cancers. All told, as all of you know, cigarettes kill approximately 500,000 people a year, and the scale of this danger has been known, scientifically known, for 60 years and generally accepted for about 40 more years on top of that. So it is a tad odd, in my opinion, that we should ever think that a handful of inexpensive and readily available trinkets and candy would somehow combat an addiction of this magnitude. So why are they such a ubiquitous tool? Well, I can't say for sure, but when I look at the history of addiction models and quick kits, there seems to have been a sweet spot where interest in smoking cessation was high and the negative reinforcement model of addiction was ascendant. And for those who don't know, the negative reinforcement model of addiction was simply this, that most compulsive drug use was driven not by the addict seeking the euphoria or pain relief or excitement offered by a drug, but rather they were trying to stop the discomforts of withdrawal. In retrospect, this model seems at best incomplete, but it was defended by the scientific observation, which remains true, that many individuals in advanced stages of dependence stop reporting getting enjoyment from their drug and start reporting needing their drug to feel normal. If the primary driver of drug use is avoiding withdrawal, then a box of supplies designed to ameliorate withdrawal symptoms would be a truly effective tool. Unfortunately, drug use during addiction is not reducible to negative reinforcement, and quick kits are not particularly good at supporting cessation, even though they do seem to have a modest ability to mitigate withdrawal. So, in order to talk about what a quick kit does or does not do, I want to do two things. I want to talk about what a quick kit is, and I want to talk about two studies that I think make the best possible case for using quick kits so that we can talk about what those researchers in those studies found and how, contrary to their summary of their results, their findings actually offer something of a warning for using these as cessation aids and actually make the case for something else. So I don't want to propose an official definition of what a quick kit is or should be. Rather, I want to offer a simple generalization of the quick kits that I've encountered. And I want to break that generalization into three parts. And we can call those the what, the why, and the who. A quick kit is a collection of items intended to promote cessation among those who receive that quick kit. I think we can further specify that in general, the quick kit is intended to be given to tobacco users, primarily cigarette smokers, as many of the items inside are geared at those who smoke, like straws or toothpicks, to satisfy oral-related urges during the quit attempt. The items inside the quick kit explain the how. The items that comprise a common quick kit tend to be of two main types: items that educate, inform, or raise awareness about smoking and cessation, and also things designed to mitigate cravings and other symptoms of withdrawal, the fun stuff. In my experience, when folks are asking for advice on what to put in a quick kit, they're primarily asking for advice on the fun stuff. Have I heard that cinnamon gum is better than mint gum? Are gumdrops better than gum? What about mint snuff? Are stress balls better than detanglers? Has anybody done a study on the effectiveness of fidget spinners? What about handheld puzzles? And it is on this point that we should be really clear. If these things matter at all, the effect is not observable given the predicted effect of the other items in the kit, the printed educational materials. And I should also say at this point that printed self-help materials don't seem to have much evidence supporting their use either. And just to repeat, when I say the effect of the fun stuff is undetectable given the predicted effect of the educational items, I mean the effect on cessation outcomes. There are potentially a lot of other effects of the gums and squeeze balls and many etch-a-sketches that you might give away that are beneficial and potentially worth pursuing, but they're not cessation effects. We'll talk more about that in the next section, but for now, I just want to present the two case studies that I previously mentioned. Between January and March 2010, 480,000 quick kits were distributed by the United Kingdom. The contents of the quick kits were determined in a multi-stage process the previous year. And these items were a health wheel, a Tangle stress reliever, a quit plan wall chart with stickers, a willpower assessment quiz, leaflets informing folks about stop smoking services and pharmaceutical services, motivational postcards, a toothbrush, and some information on stress management techniques. About 2,300 folks were randomly selected for interviews, and the important results of their interviews are here. Now, generally, these are at first glance extremely positive, and even after the scrutiny that I'm about to subject these statistics to, I think it has a strong glow about them. But what they don't have is strong evidence for use as a cessation device, and we'll return to cessation rates in just a moment. However, there is very strong evidence that the quick kits captured and maybe even drove up motivation. That's hard to determine, and as an end goal, raising motivation to quit is insufficient. However, as we'll see later, it also drove up engagement with services, and that's good. It also generally had a positive impact on people's attitudes toward the UK Stop Smoking Services offices, and seems to have had an impact on confidence as well. The people liked the quick kits, and that's an important first step, fostering future cooperation. And the second study I want to mention was a refinement of the first. So the first quit already described, and based on user feedback, the researchers added a quit planner, some graphic health warning cards, and a voucher for 1 free week of nicotine replacement therapy. And here are the results of that follow-up survey. Interestingly, the researchers note that individuals who picked up their quit kits from a pharmacy were much more likely to quit compared to those who ordered theirs online. And to me, this is probably due to differences in motivation. It's very easy to simply order a kit online. It's easy, but nevertheless harder to go in person to get one. On net, the pool of people who go into a store are very likely just more committed to their quit plan than the other group. Adding to that, researchers also found that overall, 69% of individuals redeemed their nicotine replacement therapy voucher. But among the individuals who picked up their quit kits from the pharmacy, as opposed to getting theirs in the mail, that figure was 93%. As you might expect, I do read a lot of studies about tobacco control and nicotine cessation, and I have found that many researchers seem to undervalue the role motivation plays in quitting. It determines whether or not someone tries to quit, it determines how much and what type of assistance they seek out, a point I will return to in a second, and it mediates the chances of continuous abstinence or relapse. So now I want to talk about these studies together, and first I want to talk about cessation outcomes, although there is something else that these two studies share, and I'm going to hold off on talking about that until after STEP presents. In the first study, Quit Kit 1, half of recipients tried to quit after 1 month. And when the researchers limited their analysis to just those who could possibly have been quit for a month, people who had their quit kits for a full month, 26.5% of recipients had been quit for at least 1 month. In the second study, Quit Kit 2, 3/4 of recipients had tried to quit, and 31.5% of individuals who had had their quit kits for at least a month had been quit for a month. So these are their 1 month measures, but 6-month follow-up is just more common. About half of those who are quit at 30 days are still quit at 180 days. That's sort of a general rule in the industry. So we can assume, and I think without being unfair, that these numbers are really more like 13% and 16%. And here are the 6-month figures from a meta-analysis from 2000 and its 2008 update used for the Treating Tobacco Dependence Manual. And we can see that at 13 and 16%, these quit kits are about where you would expect they would be for self-help materials, which is in fact what they were. And self-help materials are the educational pieces, the marketing materials, and typically some kind of structured instruction, like listing motivations, dependent self-assessments, and how to set a quit date. Now, this slide is pretty old. It's from 2008. So I don't like to use it very much anymore, but the studies in question are from right about the same time period as when this chart was made. However, one thing I do like to point out when I do use this slide is the jump from unaided quit attempts at 4 to 7% success and self-help at 11 to 14%. I think it's worth questioning if we're seeing the effect of the self-help materials, which is what's implied, or if we aren't seeing a reflection of the motivation of individuals who do and do not use these materials. Keep that in mind as I go through the next section, where you're going to hear numbers significantly lower than 11 to 14%, because frankly, there's a big difference between individuals who receive self-help materials and those who use self-help materials. In a separate meta-analysis from 2009 by the Cochrane Group, they found that when compared to no care at all, quit rates at 6 months using those receiving nothing and those receiving printed self-help materials alone with no face-to-face contact was about 5% in both groups. When self-help materials were added to a brief face-to-face encounter, quit rates averaged around 9% in both groups, regardless if they received self-help materials at the same time or not. And in a comparison where the face-to-face contact was with a clinician and self-help materials were used as a supplement, quit rates averaged 7%, whether or not recipients received self-help materials. And when self-help materials were used as an adjunct to nicotine replacement therapy, quit rates in both groups were 20%, and self-help materials did not seem to have an impact. Now, the authors of this study do point out a few of the problems with studying the impact of the self-help materials. And the first one they mention is really important. Basically, self-help materials are everywhere. And while that was true in 2009, it's even truer now, as the internet is better, faster, and wider spread now than it was then. So it's very hard to know if individuals who received no self-help materials from the researchers obtained no self-help materials at all. So the case for quit kits as cessation tools is just very hard to make, given what we know. So what are good cessation strategies and what role do quick kits play in our tobacco programming? Listed here as bullets are the tobacco cessation interventions receiving a letter grade of A from the United States Preventative Services Task Force. These are what we consider the evidence-based tobacco cessation interventions. In the box, I have broken out 3 actions that are necessary but insufficient to promote or support a quit attempt. And I broke these out because they can be done in a standalone or isolated fashion in person, and they will promote or support a quit attempt so long as they are connected to the provision of one or more of the bulleted items. You will note that education and assessment are in that box, and both of these can be and probably should be added to quick kits. We have, I think, covered whether we're talking about cinnamon flavored toothpicks and stress balls or printed structured guidance. Quick kits aren't really in and of themselves cessation aids, but we can add a few more things to this box. And they're going to be here. And we can add these things to quick kits as well. So how can we make the most of our quick kits? At this point, I am moving into the guidance document that you were sent yesterday. In general, we should think of 2 or 3 main audiences for our quick kits. First and most obviously is the tobacco user, a person we would like to have quit tobacco. Related to this first main audience are the friends and families of potential quitters, and I don't have any particular advice about this potential audience, like whether or not you should tailor a quit kit specifically to them. But I will say this, the messages that tobacco use is addictive, that chemicals in any tobacco products are known to cause disease, and that quitting is possible have all been said before, and they will continue to be said for the foreseeable future. So what often matters is not what is said, but who says it. Friends and family are just naturally going to be more persuasive than public health departments. We also know that people do obtain quit kits on behalf of tobacco users in their life. So we should know that some of our quit kits are likely going to be seen first by those individuals. The second or third main audience are our community partners, and we can divide our community partners into 2 main groups. Those that may refer to clinical intervention and also then to the clinical providers themselves. The quit kits themselves have 3 non-exclusive functions. And the first is fundamental. We should consider all quit kits to have a promotional or awareness raising function. The contents of quit kits are for the tobacco user, so all quit kits should contain information on any available cessation resources. The Colorado Quit Line, local substance abuse treatment centers, local tobacco treatment specialists at hospitals or clinics, the availability of pharmacotherapy. You don't necessarily want to overwhelm folks with a phone book of resources, so you can exercise some curation here. To say that a different way, there is a tendency to just pile on potential resources in the hopes that one of them might catch a tobacco user's eye and inspire them to reach out. But what we have found is that when you give people a lot of options, their tendency is to not choose any of them. And so what we want to do is really be directive here and try to send people to the resources that we think will be most helpful. So while all the content of quit kits are aimed at the tobacco user, if the target of a quit kit program is to engage with community partners, then we use the opportunity of designing and delivering the quit kit to promote other things. For potential community partners like local businesses, we may still want to be alerting them to the existence of local resources, including and especially the local treatment providers we want them to refer people to. For the providers themselves, instead, we may be using the quit kits to highlight, promote, raise awareness around best practices in making referrals to the quit line or some other best practice. We'll talk about this in a bit in the next section of the webinar, but you might also want to be raising awareness of local services that might serve as supplements to a quit attempt, local gyms and yoga studios, for example, or free recreational facilities like safe walking or biking paths, financial management courses, or other substance abuse treatment options. All of these promotional awareness raising content should be aimed at the quitters. However, the more interesting this content is, the more enticing your community partners will find it to join you in distributing them. Use the opportunity of delivering or shipping your quit kits to clinicians and other community partners to educate them on the resources inside so they can more effectively engage with the patients or clients that they give the quit kits to. Next, we should think about quit kits as an opportunity to engage. And here we should distinguish between using the quick kits to engage with our community partners and using the quick kits to encourage the recipients to engage in evidence-based resources for their quit attempts. I'm going to spend some time on this use in more detail in just a moment. The truth is that whether with tobacco users or with community partners, the primary objective of a quit kit should be engagement. This point is central. And finally, there remains the self-help purpose, the original purpose of the quit kit, to aid in recovery by mitigating withdrawal. Now, I spent the first half of this webinar saying this is an area where the evidence that it works is lacking. And I'd also add to that our ability to evaluate success on this front is low. No quit kit should be first and foremost a self-help resource, and no quit kit should solitarily be a self-help resource. Rather, it should be thought of as a promotional or engagement tool disguised as a self-help resource. I don't want to imply that the content simply doesn't matter at all. If the point of the quit kit is to engage, then the content has to be interesting to the recipients. In the case of direct delivery to tobacco users, the content should be perceived as helpful and useful. And in the case of delivery to care providers, they should also perceive the content as useful enough for their patients that they're willing to engage them in a conversation about their quit attempt. So let's talk about engagement. Because while all three are unique and viable purposes that quit kits can serve, engagement is the only one that can stand on its own. And as I've already said, all quit kits should be used to increase awareness of cessation resources, but education alone is insufficient at changing behaviors. Okay, so I'm just going to give one brief example, and then I'm going to turn it over to Tara from the STEP cessation team to provide another one. Let's assume you want that what you want to do is get an important clinic in your county to start giving more and better quitline referrals. So what you want to do is to train their staff on how to make good, effective referrals. But to do that, your first step is just building a relationship with them. So the first part of your plan is to build a quit kit that might be attractive to the patients at that clinic. The plan is to deliver 20 quit kits to them each month for a year, as long as they're going through 20 per month. And if your workload can handle the stress, maybe instead of one monthly delivery of 20, you do 5 deliveries every week. The goal here is to become a known and friendly, generous presence in that clinic. Eventually, maybe in the 4th quarter of the first year, you can see if your plan to partner can go to the next level. You ask if you can do an in-service, training staff on making referrals. You can also go through the quit kit to explain why each of the components are in there, and maybe one of those components is information about the quit line. And now you have a segue on how to make an effective quitline referral and how they can more effectively provide the quit kits to the patient, connecting their clinical operations to your public health goals. Okay, so now I'm going to stop sharing my screen and I'm going to turn it over to Tara from the STEP team.
And while I'm waiting to be able to share my screen,
there you go.
I don't know who all is on the call, but just wanted to introduce myself. I'm Tara Dunn. I am the tobacco communications specialist with the STEP team. So I work on all of our tobacco prevention and education campaigns. And today I'm going to walk through just a refresher of the materials that we have available for order through our CoHealth Resources platform. Just knowing there are some new folks on the team. As Jim mentioned, we do have some existing materials that are available for order that could be added to, a quit kit to get folks more aware of the quit line. And so I wanted to walk you through some of the materials that we have available, just knowing that, some folks are new to the team and maybe some folks haven't explored the site in a while. So it looks like, Jim, you need to stop sharing your screen and then I will be able to.
You're all set.
Awesome. Okay. So as a reminder, we only have enough CoHealth Resources logins or accounts for each one of our grantees. And so oftentimes we'll ask grantees to share accounts on CoHealth Resources because we are charged per account. And so if you do not have an account currently, please feel free to reach out to me sometime this week. This is my last week at CDPHE. So if you need a membership to CoHealth Resources and don't have a login currently, I'd be happy to assist with that. So I'm just going to walk you through kind of how the site works and what materials are available. Can you all see my screen now? Or I guess I'm asking Jim again. I'm going to assume yes. Okay. So when you log into the CoHealth Resources website, this is what you're going to see initially on your home screen. You're going to want to click Find Your Materials. Oh, and I got logged out. So hold on a second. The first thing you're going to do is log in. But also, if you do not have an account currently, you can go to cohealthresources.org and click Don't Have an Account, and then you can request an account, and we can just set you up with one. So I'm going to log back in. So after you click the home page, so let me just go back. After you click Find Your Materials, you're going to be taken to this page where you'll see a number of different materials for different programs. Scroll down to tobacco materials. And then if you go to cessation campaigns, you're going to find Quitline specific materials. So Quitline and My Life, My Quit. And here we have some Quitline posters, postcards, both in Spanish and English, which are perfect materials for putting into a Quit Kit. They're small, they're on the smaller side, 7 by 5. We have them both in English and in Spanish. And then we have them to reach priority populations as well. So we have postcards to reach pregnant populations. And then we also have palm cards as well. So these are in English and in Spanish. And then if you're trying to reach a youth audience, we have these business cards for My Life, My Quit. And, these can be both for, there's a version for parents as well as a version for youth. So if you have a specific Quit Kit focused on young people, or you have one, or if you just need materials to reach parents about how to help young people quit tobacco, these are materials that are available to you. In addition, we have these posters and flyers. Depending on your Quit Kit size, these may not be great fits. I would say probably you would want to lean more towards the postcards or the palm cards, something a little bit smaller. But we do have these available. And then I also want to mention, these are some of our older materials that we have available. But we do have a Quitline quick tip card, as well as a magnet in Spanish. These are just materials that are left over. And then a Quitline button in Spanish. And then this prescription pad. Likely, I don't think you would use this for a Quit Kit, but wanted to call out that this exists as well. And then I will also show you one additional resource that may be a little bit trickier to find. So if you are, I think it is, oh no, I'm sorry. It is in the cessation campaigns, but if you go to Express Yourself, LGBT campaign, we have these postcards specifically for LGBTQ audience as well. So just, speaking to the fact that, if you were to create a Quit Kit and wanted it to be catered to a specific audience, we do have these LGBTQ postcards available as well. And again, all of these materials are free to order. You will place an order simply by coming here and saying how many you want. So if you wanted to order 100 of these, it's going to come up saying that it's going to cost you $1, but you're going to add it to your cart and check out. It's really not going to cost you $1. We just had to quantify the amount, and then you check out. And then this is where you add your shipping information, and then proceed to place your order. So, we're constantly updating CoHealth Resources with more materials. So if there are, materials that you would like to see up here, definitely open to hearing that, specifically if you're trying to reach a specific population. But did just want to, do this as a kind of a refresher for folks to see what materials we have available currently, how to place orders. And if you have questions, feel free to reach out to me. I'm going to go ahead and stop sharing my screen and see if there are any questions currently in the chat.
I love hiding my mute button. There's nothing in there yet. This is a good opportunity to say that we are going to have time. I just have a few more slides to get through, and we'll have plenty of time for, hopefully people will have all sorts of questions for us.
Sounds great.
So thank you, Tara. Okay, so what I want to do now is hide this screen that I can't see. Okay, so I want to go back to the case studies again. I said that a few minutes ago that there was one really interesting thing about these two case studies, and a characteristic that they shared, and then I never really brought it up again, and that's this. After Quick Kit 1 was sent out, quote, this is reading from the article, as a consequence of receiving the Quick Kit, 29% of interviewees reported visiting their doctor, and 17% reported visiting their pharmacist about quitting. Additionally, 24% reported looking up the details of their local Stop Smoking Services office, 13% that they had contacted that office, and 11% reported having visited the office. And after Quick Kit 2, quote, visits to the pharmacy and doctor regarding quitting were reported by 11 and 16% of respondents respectively. And that doesn't even include about a third of nicotine replacement therapy users who went to their pharmacists to get more, and another 16% who had more prescribed for them. Which is all to say that these two Quit Kits, whether they intended to or not, engaged these users with public health and with local medical professionals as part of the quit attempt that the Quit Kits potentially inspired. So we know that this engagement effect is possible. We just had to figure out ways to maximize it and track it. So there we go. And so that discussion moves us into a sort of a broader discussion about using Quit Kits effectively. We talked a lot about what Quick Kits don't do, so what do they do? Because knowing what a Quick Kit can do is the first step in designing a program that maximizes actual possible effects. We've discussed a bit about engagement, which I think is the most important function a Quick Kit can perform, getting people to connect with evidence-based resources either directly through prompts in the Quick Kit or by connecting them to professionals who can do that work. And I listed a few examples of other possible objectives on this slide. And this list is by no means complete. I can already think of things I couldn't get on there, but I think it captures most of the major ones because this slide deck and therefore this slide will be available afterward. I don't see any reason to read through each of these one by one because these are really just more specific examples of the promotional engagement and structured support roles that I introduced at the very beginning of this third part. I would like to highlight the final bullet point though, because I've only kind of talked about it as a possibility. Basically, a Quit Kit might inspire a quit attempt. And that seems to have been the case with the studies that I presented. In each of those, far more people tried to quit than I think we could have reasonably expected without the intervention. But not everybody who tried made it. At that point, they were about as successful as Selfhelp Materials would have predicted. However, knowing that they might inspire quit attempts is a good midpoint. Like, we don't want to just send Quick Kits out under the assumption that they're going to inspire quit attempts. What we want to do is say, if they do inspire quit attempts, how are we going to support that quit attempt, right? So that's the fact that they might inspire a quit attempt is sort of our midpoint. And it's the question is, what does the Quick Kit do to move past the point of inspiration to support? And that leads us into a discussion on some basic considerations. The least effective way to deploy a Quick Kit is directly to the tobacco user. And I think, as I've repeatedly said or implied, the best way to do is to get the Quick Kits to care providers, because when care providers advise people to quit, the user is twice as likely to try. And one reason that providers give us for not engaging in that conversation, not starting that conversation with their patients, is because they don't know what to do if the patient says they're interested in quitting. So giving them a Quick Kit can be that thing that they can do if their patient says, yeah, I'm interested. Another thing providers say is that they don't know what to say about quitting. So explaining to them the hows and whys of the Quick Kit so that they can then use that as the structure for their conversation with their patients can be that thing they say they're lacking. But just to say that it's the least effective way, it's not the same thing as saying it's not effective at all. And that, but it is the simplest model. And so I'd like to sort of keep that one in mind as we start this basic considerations section. We should always keep in mind, before I kind of go through this, that there's rarely an instance where you're choosing between some choice that's 100% good and another one that's 100% bad. Rather, we're just making trade-offs and trying to make the best possible ones. For example, sometimes just for a point of efficiency, we can make the most quick kits, but we can make the highest quantity of quick kits by ordering and collating all of our materials at once and just making a lot of quick kits for a very broad audience. So we'd be deploying those quick kits, we'd be sending them out in the community in a lot of different ways. But the trade-off there is that thing that saves us time and money may reduce the effectiveness of the quick kits altogether. Quick kits that are going to be handed out by hand at a health fair, for example, where the goal is to start conversations directly with tobacco users in your community, that quick kit should look very different than those quick kits that we would give to a local medical clinic to be handed out to their specific patients. Nevertheless, we can choose to save time and money by making these identical quick kits for these entirely two separate purposes. At any rate, in the direct-to-consumer model, we can have the biggest impact if we tailor the materials inside, both to who the ideal recipient is and what we want them to do. So Tara just gave a lot of good examples of some materials that you can get to put into your quick kits that are made for specific audiences. They'd be made for specific deployments. And I think that's a really great way to begin your tobacco quick kit programming. So, but it's not just who they are, but also what we want them to do. So if we want to get them to call the quit line, we wouldn't necessarily want to provide them the names of a lot of other resources, maybe no other resources. Or if we partnered with a local hospital to promote their tobacco-free educational group, that would be the resource we'd want to highlight instead of the quit line or others, which is all to say that there's this tendency to want to give people these gigantic lists of things. Look at all these resources that are available to you, as if they just flip through this gigantic column of material, one of those things might engage them or attract them or give them confidence. And really, it's almost the opposite. When you hand people a whole bunch of resources, their tendency is to use none of them. So we want to really be specific about what we want them to do and then give them the materials and the means to do that one thing. I think there are a lot of acceptable targets for action in a quick kit. That's the second set of bullets. But just to be clear, really it's engagement that we're really focused on. All these other things would be things that you could concentrate on the way to engagement. And then finally, also recognize that the way that you distribute the quick kits can be can determine some things about the nature of your audience, right? And so that becomes part of your programming decision making. And I'll talk about that. Well, actually, one way to think about that is we know that quick kits can increase the motivation to quit. However, they are most effective in that regard amongst those who are already pretty motivated. In the case studies, the way that they distributed the quick kits in both cases was people had to order them. They either had to order them online or they had to go into a pharmacy and order them there. So in either of those two situations, you already have somebody who's more motivated than an individual who's just walking by a booth and just gets handed a quick kit, right? So as you make them, and of course, I'm sorry, and as I already mentioned, going into the pharmacy is slightly better than ordering them online. So you have these tiers of selection bias where you're aiming who gets the quick kit by motivation through the deployment methodology, through the distribution methodology. And that is going to mean that we're going to hand out less quick kits, fewer quick kits, but each one that we hand out is more likely to end up in the hands of somebody who's really motivated to quit. And that's the kind of, and use those materials, right? And that's the individual for whom self-help materials can double or triple their chances of quitting. And then that final bullet point is, how are you going to measure the success? You need to start your programming, your tobacco quick kit programming, with the question of how you're going to measure success. I have included here a list of a few self-help resources that might be useful. And just to be clear, again, I'm not going to go through this one point by point, but I do think it's worth summarizing kind of what I mean by structured guidance. I keep saying that over and over again, and what does that really mean? Educational materials alone aren't what we would consider structured materials. So what we're talking about are practical tools that are included for specific actionable purposes. So you'll see, for example, that I've added to the slide of things, the Fagerstrom test for nicotine dependence. And some of you know what that is, and those of you who don't, it's a validated instrument for measuring dependence, and then the assessment then points to a ballpark nicotine replacement therapy recommendation. So you can include this short questionnaire. It's 6 questions. You can modify it a little bit for literacy purposes. You can also use the 2-question, the Fagerstrom is 6 questions that you can replace it with the 2-question heaviness of smoking index if you're looking to save space or make things that are more legible by virtue of them being bigger fonts or whatever. Whichever one you use, that questionnaire can help provide to that person a sense of their physical dependence, and then the results of their assessment can then be tied to that nicotine replacement therapy recommendation, other educational materials on nicotine replacement therapy, including how they might get it, right? And so they would come equipped to their physician or their other care provider to say, hey, I gave myself this assessment. It's saying I should have, the 14 milligram patch. What do you think about that? And really helping the provider by having the patient at this point prompt that conversation with very specific questions that you provided them via the quick kit. And again, I'm not going to go through this all one by one, but finally, at the end, you can see I've listed education on withdrawal symptoms and mitigation strategies. And I hope that if you have already scanned ahead of me and saw that, you're like, that's boring. And Jim said it's supposed to be engaging, and that is not going to be engaging. And you're absolutely right. Rather than just listing withdrawal symptoms and when they might show up, and then listing all the mitigation strategies that you can think of, refer to the fun stuff, the mitigation instruments that you've added to the quick kit. So if they use them appropriately, know how to use them, and depending on what you've added, if that person needs more, maybe connect them to a way for them to get more, which may mean coming back to you for a second quick kit, or going to a local pharmacy or a supermarket or a dollar store or whatever the case may be. Finally, I just want to do a couple points on data. That was the final bullet point 2 slides ago. It's incumbent on each of us to make sure that the money we spend on our tobacco work has the desired effects. And honestly, all programs are going to have some non-effects, flyers that get thrown away, or quick kits that stay unopened on shelves. But the bottom line is that good intentions simply just aren't enough. We can't just send a quick kit out into the world without attempting to find out if it's doing what we intended it for it to do. And of course, maybe looking for opportunities for that quick kit to do its job better the next time it goes out into the world. And I think the possibilities of things that we could measure are really only limited by our imaginations, and of course, by the program design itself. So rather than talk about specific ideas of how we can measure impact, although we can certainly do that if you have specific questions, I thought I would just mention a few guidelines, things I would think about if I were about to send a bunch of quick kits out into my community. The first thing I would do when thinking about things that I can measure are literally just listing the things that can be counted that are associated with my program. Counts are normally pretty easy to discover and record, and they're often pretty easy to affect or to change with simple program adjustments. Did you give out 250 quick kits last year? Can you give out 300 this year? Did it inspire 15 conversations? Can we make it 18? That kind of thing. But just because you can count a thing doesn't necessarily mean you should. Some things you can count may be out of your power to control. For example, if you want to count how many quick kits get in the hands of actual users, but your distribution method is to give them to clinics, then you might be a little bit restrained in your ability, or constrained in your ability, to find out how many actually got into the hands of patients. And the clinic itself may be a little bit constrained because they can only give the quick kits out to positively screened tobacco users, and they may be maxing that capacity. And we're not going to necessarily have anybody go out and recruit people to give quick kits to. So count the things that you do, and maybe then limit it to the things that you can theoretically change. I also want to stress that engagement is our #1 target here, and engagement can be pretty qualitative. I definitely encourage you to measure basic things like the number of conversations that you've had because of your quick kits. The length of those conversations can be a good proxy for the quality and content of things that you've shared. And then of course, anytime you can track any follow-up actions by the people that you've talked to. But also don't forget to try to find out how people felt about those conversations and whether anybody's attitudes changed about the possibility of quitting or about the esteem in which they hold your departments. And I'm just going to stop there. This is how you can contact me as always. And we have about 13 minutes for questions. And I see some things have shown up in the chat since the last time I closed that window. That question is for Tara. Tara somebody will tell us who to reach out to instead of Tara when Tara's gone. Sorry you're leaving, Tara. I just learned about that earlier myself. Okay.
Thanks, Jim. Yeah, I'll be sending that information out in a newsletter this week. Hopefully that went through.
Okay, so we do have anonymous attendee who has asked, how would you suggest adapting a quick kit for youth vaping? Any best practice ideas or any research you've seen around quick kits in youth? I don't know if anybody from RMC is on the line, but that might be a better question for them. But here are some things that I would say while if anybody from RMC on the line would like to take a swing at this, I will call up my participants window and see if you raise your hand and I can unmute your line. But some things to consider is, first of all, making sure that that all of your materials are, if you want an effect in vaping, you need to build confidence that the quick kit itself is about vaping and for vapors. And so don't muddy the waters by adding a bunch of other tobacco product information, including cigarette information. Really target it toward vape and vaping. Don't jump immediately to the most sensational scare tactics. Understand that a lot of vapors have either moved to vaping because they've heard it's healthier, that it's non-addictive. We might have to be engaging in some myth busting, but also they're potentially plugged into the sort of the vaping user community online. And one of their tactics is to make us look ridiculous by basically, like, anytime we say like, oh, vape e-cigs are exploding in people's pockets, they know that that's an exaggeration. I mean, I'm not saying it doesn't happen, but that is an example of like us, quote unquote, exaggerating the harms in order to scare them out of rational decision making and just to make the decision we want them to make. So just making sure that the information you provide is true and balanced and coming from a place of care and not fear mongering. Fear mongering doesn't work. The second thing that I always say when I'm offering counsel on engaging with youth is make sure that you have youth involved in creating the materials that you give to other youth. They're just going to be more fluent in the language and the graphic aesthetic and the distribution methodologies that might work best, and really getting them involved from the very, very start. And again, this is another situation too, where nicotine replacement therapy. So right now we still don't have any evidence that it is particularly effective in individuals under 18. And so the engagement strategy here really is to get that person, that youth recipient, to talk to someone. It's the psychosocial interventions that are going to work best in that audience for now. Thank you.
Jim, were there other?
Oh,
sorry. I was going to ask if there were any other questions. Otherwise, I was just going to mention something briefly about the process for quick kits and requesting to do quick kits.
No questions right now, so jump on in there.
Awesome. So one thing that I didn't mention is that in terms of requesting to use step dollars to create quick kits, we wanted to put together a similar process to what we have currently for our media requests. And so essentially creating a form, it will be more automated than you've seen in the past for our media submission forms. So in the past, we've had a Word document that you filled out. We are actually updating that so that media requests can be submitted via a Google form, which will be great. And that's the same format we're going to be using for quick kits as well. I will say I'm not sure, in the interim, while my position is vacant, we may not be accepting submissions for quick kits. We will send out that guidance, likely in this newsletter as well. But I did just want to mention that that is going to be the process we're moving towards, so that, if you are interested in pursuing quick kits, we ask questions about who your audience is, what your goal is, how you plan to evaluate your quick kit success, and all of those kinds of details, which will help us help you in creating a quick kit that is going to be successful. So be on the lookout for some communication regarding that. Hopefully in this week's newsletter, if not the following newsletter.
Great, thank you, Tara. Other questions, comments, concerns, pushback, burn it all to the ground?
I also saw Michelle drop something in here in the chat to remind folks that the draft quick kit guidance currently has an appendix in it that has a literature review on the use of quick kits with youth audiences. And then I think one of the other things we had talked about, Michelle and I, was the fact that there are other resources in addition to what is currently available on CoHealth Resources that you can use for quick kits as well. So I think that might also be a part of the quick kit guidance as well, is, in the appendix section, I believe Judith is working on kind of filling that section out with more materials that folks may consider including in quick kits, aside from the materials that we have available.
I'm going to add to that too. And I wasn't sure if I was going to have room to put it actually in the content. So I'll just say it here, since that was a pretty good segue. There are a lot of different ways that we can use quick kits to engage. And I know that engage is buzzy, it's kind of a buzzy terminology. So if that word is not, I try to hit it in define it in a couple different ways throughout. So if that's still confusing, by all means, let me know. But one way that we talked about engaging is like taking the quick kits in bundles, right, to community partners for them to distribute on your behalf, and then on their shared behalf, and then use the quick kits as a conversational prompt. That was really sort of a unidirectional way. The other way to consider about engaging is reaching out to your local community for content. So I mentioned briefly that you could appeal to community partners that are supplemental to a quit attempt. And what I mean by that is, we know that for example, one of the major reasons that people smoke or vape or use nicotine in general is for stress management. And we know that stress and acute episodes of high stress is often cited as like the #1 reason that people relapse from a quit attempt. And so it's been looked at in the literature on whether or not we can target stress management as a way of independently getting cessation. And we can't get it independent. We can't, if we give people a bunch of stress management tools and they're already smokers and we don't address the nicotine habit, they're going to continue to be smokers who are just better at solving their stress, okay? Because they have an addiction that we have to address, and we have to address it independently. That being said, we do see minor better successes in those people who do simultaneously work on skills development, stress management being one of those. So, there might be, like I said, in the content of the webinar, reaching out to local gyms and yoga studios as potential referral sources that people could use to supplement their quit attempts. But it's also the case that gyms and yoga studios have marketing strategies, and they sometimes create tchotchkes and pens and stress balls, and they sometimes create coupons and coupon codes and free guest passes. And those can be interesting, enticing content, and getting that content in there is their way of contributing to you. That makes them feel good. You're also marketing for them. That's your sort of give back to them. And so you're developing partners in that direction as well, if that makes sense. And so sometimes you can have some sort of like maybe some weird thing, because the tchotchke that they develop for their marketing strategy is something just really off the wall, something that's super fun for their organization. It might make your quick hit look weird, but the partnership is there, and that's sort of almost the bigger deal. Terry says, should I involve community partners in the process of developing the quick kits? Has anyone done this? Where in the process should they be included? Okay, so it's a great question. And so there's a couple different ways to do that. So one way is what I just said, like reaching out to the community partners to see if they want to add anything to the quick kits, things that they have found helpful, things that they know that their client base, their patient base is interested in receiving. And if they have access to those things, definitely getting them involved. For the real stuff that people would find helpful in mitigating the effects of withdrawal, opening it up to the tobacco users in your community to talk about, or the even better, like the ex-tobacco users in your community to comment on the things that they used, right? Some of these things tend to have a cultural or historical flavor to them. And so you want to make sure that things are resonating with the people who are trying to make a quick kit today in the region where those quick kits are deployed. And so it's really a good idea to, I mean, that could be a money suck. I always get a little hesitant about just saying, oh, what we need to do is 6 months of focus groups to determine that we should put in Etch-a-Sketches or mini Etch-a-Sketches or whatever. I mean, I read that list of materials that was in that first quick kit experiment done in the UK, and that didn't sound super like wacky to me. That seemed like there's a health and wellness wheel, there's a detangler, and there's instructions on stress management. Like, yeah, they didn't need 6 months of focus groups, which is what they used to come up with that list. And I feel like I could send you out and say, do your focus groups, and you're just going to come up with the same materials that everybody else comes up with. But if you do want something specific, if you really want to engage the community, then getting them involved in the creation process is always a good idea. We still have time for, depending on how long it takes me to answer, maybe 2 or 3 more questions. Oh, and Terry, since I'm just here waiting for other questions to roll in, the process for the UK, now this was the UK, this was the nationwide push out. I don't expect anybody to have this level of resources for this particular thing, but they involved them in 2 different ways, right? They involved several focus groups with tobacco users and professionals to create the first quick kit, and then they asked, when they were doing their follow-up interviews with the 2,300 individuals that they randomly selected out of the 480,000 they distributed, they asked those folks what they would have found more useful in the quick kits, and that's how they came up with the quick kit that made it to the second round. And so when to engage them in the process is kind of whenever. There's like just sort of like a Ben Franklin-ish, if anybody's heard of the Ben Franklin method of ingratiating folks to your project, and that's just ask anybody for their advice. People love to give their advice. They love to contribute things, and then it gets them invested in the success too. So I'd say as long as you have a program in the works, if it's going to take you all year, or if you have a 2 or 3 year plan, be inviting input all the time. You never know when somebody you have is going to burn out and stop playing along, and you never know who's out there just waiting for you to talk to them to join up. Got to get that new blood infusion in there all the time. We have about one more minute or less. All right, everybody, as we're wrapping up in the final minutes. No, thank you, Dee Dee. Do reach out for any question, quick kits or otherwise, as long as it's cessation, youth, or adults. If it's a workplace or clinical, especially if it's between clinical and public health, I'm always here. Even if you're not technically in the cessation pillar, that doesn't matter. If you're not a strategic grantee, if you're fundamental or foundational, whatever, I'm always here. I work at the university. I get paid to answer questions. So please shoot them to me anytime. If you want more specific advice or counsel around your specific cessation programming, by all means, please reach out. I'm always here, and it's 3 o'clock, so I'm going to go ahead and hit leave the meeting for everybody. Thank you all.